Hello everyone, and welcome to the teleconference, Critical Inquiry and Evidence-Informed Practice. My name is Angela McNabb, and I am the Outreach Consultant for Mental Health, Corrections, Complex Continuing Care, and Rehab. With me today is my colleague Myra Craik. Myra is the Outreach Consultant for Community and Public Health. Myra and I are very pleased to be joined today by two guest speakers, Karen Riddell, Director, Professional Practice and Operations at Windsor Regional Hospital, and Nancy Lefebre, Chief Clinical Executive and Senior VP, Knowledge and Practice, St. Elizabeth Healthcare. Also joining us today is Lori Adler, Manager for Practice Standards here at the college. The objectives for today's teleconference are to explain the regulatory requirements for evidence-informed practice, to discuss how critical inquiry supports safe practice, and to share examples of how nurses apply critical inquiry in practice. As many of you know, the college is currently revising the medication practice standard. As part of the process of revision, members were welcome to provide feedback on a draft of the standard that was available online in November of 2014. The draft medication standard is quite different from the current standard, as it is principle-based and much shorter. While feedback on the draft was overwhelmingly supportive, some members expressed a need for further support in understanding the concepts in the draft document that we will be talking about today. Members expressed a need for support in understanding what expectations for critical inquiry and evidence-informed practice might look like in direct practice. This is the main reason that we wanted to partner with our clinical experts in today's teleconference. In our discussion today, we will not only address C&O expectations, but also provide listeners with examples of how nurses are currently upholding these expectations in their practice. In addition to reflecting on your own practice throughout this discussion, we encourage you to think about the organizationally based policies that support medication practice in your setting. This slide depicts 4 of the main factors that support nursing practice in Ontario. The Nursing Act and the Regulated Health Professions Act, both of 1991, outline the roles and responsibility of the college, as well as outlining the privileges granted to nurses in Ontario. In addition, there may be other legislation that may further outline expectations in particular practice settings. For example, the Personal Health Information Protection Act, the Healthcare Consent Act, or the Mental Health Act. The college has many standards, guidelines, and fact sheets that outline nurses' accountability for practice. Some of these expectations will be the focus of our discussion today. The organization where you work will have policies and procedures further defining expectations for practice in your setting. These expectations should be in keeping with the expectations of the college and of relevant legislation. Finally, each individual nurse needs to be aware of their individual level of competence in the areas where they require further support or knowledge. To complete the process, the center and focus of care is the client. Together with the client, we identify their needs and wishes and work together to develop the plan of care. Expectations for critical inquiry and evidence-informed practice are found throughout college documents. We'll start on the next slide by defining our key terms before moving into a dialogue with our guest speakers. Competency is addressed in the C&O Professional Standards document. It's defined as the demonstrated knowledge, skill, ability, and judgment required for safe and ethical nursing practice. Competency will look different for each nurse as it is formed throughout your career. It's not just based on what you learned in school, but is based on practice reflection and participation in continuous learning. This will be unique for each nurse based on their individual career path. Critical inquiry is defined in the document, Competencies for Entry-Level Registered Nurse Practice. Critical inquiry expands on the meaning of critical thinking to encompass critical reflection on actions. It is a process where practitioners examine ideas, assumptions, principles, conclusions, beliefs, and actions in the context of nursing practice. The importance of having a questioning mind is essential. It's about being aware of the impact of evolving changes in practice, looking at evidence to inform your practice, and to support the evolution of safe and ethical care. It is about ongoing practice reflection. Evidence-informed practice is described in the Entry to Practice for Registered Practical Nurses in Ontario document. The purpose of evidence-informed practice is to examine strategies that improve client outcomes. Information is gathered from multiple sources, such as the client perspective, research, national guidelines, policies, expert opinion, and quality improvement data. Now I would like you to move to slide 9, and I will hand the line over to Myra.
The need for evidence-informed practice is reiterated in the professional standards. One thing we want to highlight is the point that technical and cognitive aspects of care are closely related and cannot be separated. This simply means that effective clinical skills are based on evidence. Nurses incorporate research into their practice. As research provides new evidence, there are changes to nursing practice, and this is really an ongoing, evolving process. The need for networks to share best practice is also identified in the professional standards. This is especially important when nurses are working in isolation, such as nurses who have their own business and nurses in remote parts of the province. The Entry to Practice Competencies for Ontario RPNs and the Competencies for Entry-Level Registered Nurse Practice outline the expectations for registered nurse and registered practical nurse practice upon entry, but also ongoing registration with the college. They guide the assessment of members' continuing competence for maintaining their registration with the college. There's several key points that we'd like to highlight. All nurses are accountable for their own decisions and actions and for maintaining competence throughout their careers. Nurses must assume responsibility for their own professional development and sharing of knowledge with others. And part of reflective practice for all nurses is to be aware of the entry to practice competencies. For example, the use of communications technology such as social media is now included as part of the entry to practice competencies. This may not have been part of your foundational knowledge, but it is a current expectation. We're looking now at components from the entry to practice indicators. Critical inquiry and evidence-informed practice are concepts that are included in multiple entry to practice indicators. We've included a few indicators in relation to responsibility and accountability that are especially applicable to the discussion in this teleconference. The indicators in this slide highlight the need for nurses to demonstrate critical inquiry in relation to change, to use critical thinking and problem solving in all aspects of nursing care. We'd like to ask our practice expert what this looks like in the practice setting. Let's start with talking about how the frontline nurse uses critical inquiry when they're faced with a change in their practice. We'll start with Nancy. What does the use of critical inquiry in relation to a change in practice look like for nurses working in the community?
Well, I would say, first of all, that, we sometimes get concerned by the use of the language that we have. And so in terms of critical inquiry, it's just really all about asking good questions. And it can sound rather daunting and complex, but it's not really. It's taking a look at the situation at hand, asking good questions, looking for sources of information that can help respond to a question at hand. It is really all about, and I think you mentioned this before, examining our ideas, our assumptions. It's a spirit of inquiry and logical reasoning. I think it's, we go back to the nursing process. It is somewhat exactly like that, where you assess, you question, you define the problem, and you move forward with a solution, and then you evaluate whether the solution's working or not. But it's really not taking things for face value, but asking questions and having that spirit of inquiry like we used to when we were young.
Mm-hmm. Thanks, Nancy. Karen, do you have anything to add to this discussion?
Sure. I think just to build on what Nancy was saying, it's really important to keep in mind that this really exists along a continuum. It can be something that's very simple to something that's very complex. And as Nancy mentioned, based on your experience, the situation at hand, you may have more or less time to really look at and gather that evidence and rely more heavily perhaps on the experts that are around you, other members of the healthcare team, for example, whether it's a pharmacist, a physician, a more experienced nurse, and really capturing that information and being able to apply it to the actual situation that you're in. Other times, of course, you might have more time and be able to actually access facility policies, meet with your clinical practice leaders and get some support for any additional education or training that you might require, or do some actual research. So again, it can be very small and quick, or it can be more complex. So it's that whole continuum.
Thank you, Karen. We were asked a question, is critical inquiry a nice-to-know or a need-to-know skill? So, Karen, maybe you could elaborate on this statement through application again to the acute care setting.
Sure. I think we'd probably all agree on the call that it's definitely a need-to-know skill. The speed at which healthcare is changing really requires us to be very nimble and dynamic with regards to how we're practicing. We have to be able to keep up with the changes. We have to be proactive, giving thought to what resources you currently have available to you in your workplace, whether they're electronic, paper-based, human-based, looking for trends that you're seeing on your unit. So are you seeing higher, or in your practice in the community, are you seeing higher acuity patients or a higher frequency of a particular treatment or medication? And what's going on globally in the community, whether it's local, provincially, or national or international. I think we've all seen a lot of change in the last few months, and I'll just speak specifically towards infection control because that's part of my portfolio, but how many of us probably thought that we would have to learn about taking care of or screening for Ebola? And then, of course, now we're just coming out at the tail end of the influenza season with a vaccine that wasn't effective, so looking at our practices around infection control and prevention, and then looking at now what's going on with the measles outbreak. So I think, and that's just one facet of nursing practice and infection control, so you can see how there's multiple variables and multiple changes that are occurring on an ongoing basis, and we have to keep our eyes and ears open and make sure that we're reflecting on our practice and practice areas and what changes we need to be making.
Those are great examples, Karen. Is there anything to add, Nancy?
No, I don't think so.
Okay. From the CNO perspective, as noted in the indicators in the slide, critical inquiries is a requirement for nurses throughout their career and is part of the practice of nurses in all settings. In the previous slide on professional standards, again, it said that nurses employ knowledge in the performance of clinical skills because the cognitive and technical aspects of care are closely related and can't be separated. Is there any further comments on that statement, Nancy?
Well, I know, yes and no, I guess. I think it's a very accurate statement, and I think, if we think of ourselves as knowledge workers within the system, everything that we do is actually based on evidence of some type, whether it's evidence from the research literature, whether it's evidence from an expert, whether it's evidence from an experienced colleague, or whether it's data and information that is brought forward from the client. And so I think it's simple to say that, as knowledge workers, we've moved way beyond just completing a task. That we have to really understand what underlies the clinical skill, what's the practice that's related to it, what's the evidence, and, to stay curious to ask ourselves, what is behind what it is that I'm doing, and if we don't think that it's working, or we feel that there's some new evidence to suggest we should be doing something else, then we should be acting on those things. And I think we talked earlier about really looking at little small tests of change to be moving forward.
Great, and it's Angela speaking here again. Another question. Do you have any suggestions for how nurse leaders can encourage the use of critical inquiry? And we'll begin with Nancy, and then if we could ask Karen to comment after.
Sure. Well, I think, first and foremost, I think nurse leaders can be role models, and they can be demonstrating the spirit of critical inquiry and the curious nature by asking good questions and by reflecting on their own practice or reflecting on the practice on the floor or in the community or in patient discussions when you're discussing patient rounds, those kinds of things. So I think that they can be role modeling. I think we can also be accountable for allocating and dedicating resources to support nurses in utilizing evidence-informed decision-making. I don't know that it's realistic that we can expect in a busy day that nurses are going to have the time to do their own critical appraisal of existing research. So I think that our job is to identify what are the resources where we can get summaries of information, where we can be distilling that information in terms of best practice guidelines, where we can be allocating resources or bringing in resources from outside of our own organizations. And I think that also we can be trying to dedicate some time to have a moment for reflective practice and debriefing around certain situations, to be having a good dialogue around what was the nature of the evidence that was informing decisions, what did we learn from that, what was the outcome, how might we do things differently next time. So I think there's a number of things that nurse leaders can do. I think that they really do signal, first and foremost, that evidence-informed decision-making or evidence-informed practice is important. I think that's a key role they play, and then allocating the resources, time, education accordingly.
Great. And Karen, anything to add to that at all?
Actually, Nancy gave a great answer to that question. The only thing I would add is just providing that encouragement for that engagement. I think it's, as Nancy identified, it's really important to give the time and allocate the resources, but we need to encourage staff because it does take a lot of courage to bring changes forward and to implement changes. And, they may not always have their peers' support, but that's the only way we're going to move from, that we've always done it that way type of culture to I wonder if we can do it that way type of culture on a unit. And it really supports that patient-focused care and looking at how do we build evidence into our practice and how do we discuss rationale and utilize critical inquiry in our practice.
Yeah. Karen, I think that's an excellent comment, and I, reflecting on my own practice over the years and remembering as a new grad in particular, or somebody who's been only been practicing for 2 years, asking why are we doing it this way, or why are we doing it this way, and it can really frustrate people that have been in the practice setting for a long time to have somebody come in and be questioning all the time. But I think we have that accountability as individuals to better understand why we're practicing a certain way, and to challenge those kinds of old, we always do it this way in a thoughtful and mindful way. And I think as nurse leaders, your point is exactly right, to create that culture and that environment that, no question is too silly to ask. And that, we should, as practitioners, be pretty comfortable that we have the evidence to support what it is that we're doing, and if not, to look for it, and if not, to be changing practice as well. So I think, those are the best, richest environments for nurses to be working within.
Great. And I think you've kind of segued into this question a little bit and touched on it, but what are the benefits to the individual nurse who uses critical inquiry in indirect practice? Karen, maybe you could begin with that one.
Yes, for sure. Well, I think I've seen a lot of examples over the years, both in my own practice as well as nurses that I've worked with, and I think one of the keys is that direct care providers, whether they're nurses or any other discipline, really appreciate the opportunity to work on initiatives and being engaged in the research and implementing, as Nancy had mentioned before, those small tests of change. So let's just try one little thing that's different and see how that works. And if it doesn't work, we'll move on and we'll try something new. And really having an opportunity to sit down and discuss what the rationale is for what it is that they're doing and where there might be some benefits to making changes for their patients and really improving the practice on their unit. And I think, again, just to reiterate, it's really, really important that we do make time for staff to be able to reflect on their practice, even if it's just on a regular basis, having little short safety huddles each day or at staff meetings having discussions about, trends that nurses are seeing on their unit and really looking at what are some things that we need to do in our unit, in our hospital, in our program, in our community practice to really make sure that we are practicing to the best evidence and really are having that impact on our clients that we want to have. Just to reiterate, again, it can be very rewarding for staff, and it definitely leads to positive outcomes for our patients.
Nancy, anything to add to that at all?
Well, I do think that if, we like to see that what we're doing has a positive impact and outcome for patients. And so, that's our raison d'etre in terms of going into nursing. So I think if we can be confident in the evidence that we're using, and we can see that practice that's based on evidence is having a positive impact on outcomes, then it does reinforce our abilities as clinicians. It reinforces our confidence, and it makes us more confident, I guess, in terms of our decision making.
Great. Okay, and one more question then. I'll start with Nancy. What mechanisms do you have in place for continuous quality improvement?
So we have a number of mechanisms in place within our organization, but I think the key one, and this kind of relates back to your first question around benefits around critical inquiry, and that is we have an audit and feedback mechanism within the organization where we're collecting data and information about client outcomes. The interventions are based on evidence. We're collecting the outcomes that are achieved as a result of implementing those specific practices that are based on evidence, and that mechanisms are fed right back to the frontline nurse. It's fed back to the manager and supervisor of the area, and the data is rolled up to a quality council, as well as it's reported up to the quality committee of the board. And I have found in my years that there is nothing better than having the data and the evidence at hand that one can take a look at to demonstrate a practice change and the impact of a practice change, because it takes all of the emotion and the guesswork and the opinion out of what is actually taking place and gives you the facts. And so, it's a very powerful tool to be having evidence and data in a feedback mechanism to inform you of how you're practicing and what difference your practice is making or not. And then it allows you to be able to make a change, adjust the course of treatment or the plan of action, and then measure that as well. And I've also found that engaging patients in that process and that review of data, whether it's how well a wound is healing, how well pain is being managed as a couple of examples, is also very, very helpful in terms of patient engagement, but also in terms of moving care forward. So we have, that taking place within the organization. We have a clinical excellence and safety committee where much of this information is reported up, and as I said, then it goes to a broader excellence council and then up to the quality committee of the board in terms of how well we are doing in relation to quality improvement initiatives, or we're looking at the data and then we're making quality improvement initiatives. And Karen talked about it earlier, too, in terms of some are small tests of change, some are larger scale initiatives, but we can immediately get the feedback to see how well we're doing or where else we need to be enhancing those kinds of changes.
Great. And Karen, from your perspective around continuous quality improvement?
So we actually have a very similar structure in the hospital that Nancy actually just described. Our committees might be called something different, but we certainly are looking at, on a regular basis, we have our corporate patient safety indicators. Those are reported out monthly. We have weekly patient safety huddles where we report out on our patient safety indicators, and then there are unit-based huddles where that information is shared. And I think what's really key with that, and Nancy alluded to it, is you have to have that data and evidence to show both where changes in practice are benefiting patients, but also where changes in practice are required. It's very difficult as a bedside or direct care provider to see the trends that are occurring when they might only be seeing one-ofs here and there. But when you look at the overall results for a particular area, you can really start to see trends, whether it's an increase in falls or medication errors or hospital-acquired infections. And that makes it much more tangible than us as leaders coming and saying, you know what, we have to do better with our hand hygiene. We can really start having those discussions, looking at trends on that particular unit with that particular patient population, and really making the initiative something that makes sense to the nurse that is actually having to do the work. and getting them engaged in the process of improvement, because we know it's not going to work without the bedside nurse being able to perform the work. We can sit and we can write a policy, but if nobody can actually live up to it because there's missing resources, then it's not going to be effective. So I think data is a great leverage for quality improvement, and it's certainly necessary. There's a saying, and I'm probably misquoting it, but if you can't measure it, you can't change it. So we certainly have to be measuring things before we can do that.
Yeah, and Karen, we often talk about, the power of one and really making that data relevant and meaningful to the clinician. So, in terms of how does this tell a story about the patient's care, how does this tell a story about your practice and the impact that you're having, and then, how can you as an individual change that and impact things in a different way?
Yeah, and I'll just add to that before we move on is another strategy that we have used with great success is the patient's story.
Yeah.
So actually, on a monthly basis at our Quality of Care Committee, there's actually a patient story presented, and quite often it's the patient themselves or their family that comes and talks to our board committee, and they talk about their experience at the hospital, what went well, what didn't go well. And the staff from those areas are invited to those presentations and are engaged in that process. So when there's great things that happen, they're getting that feedback. And when there's some opportunities, they're also having for improvement. They're also getting to hear that as well. And really, it's not just a dot then on a graph, right? It's a person that they've connected with, and it makes it much more real. And it really does galvanize that energy to initiate change, and it really does make it real for staff. So the patient story, circling back again, looking at client communication of their wishes and what they need, it really circles right back to that.
It's Myra. Thanks so much for very concrete examples. Way back in, I think, the introduction slide, Angela mentioned that we had feedback from around the medication standard when it was online, and the need for policy in relation to the use of a principle-based document was identified as one of the concerns. Nancy, could you tell us your thoughts on this?
Sure. I'm not so sure if it's a policy that we need in relation to principle-based care or principle-based policies or an approach. But that's exactly what I don't know that I look at it as a policy, but I look at it more of an approach or a philosophy or a culture where we're working with knowledge workers within the system who have come through, gotten a good education, who have access to good evidence and information, who have access to experts, who do practice critical inquiry on an ongoing basis. So I don't know that we need a policy to guide the use of principle-based documents, but I think it's more a philosophy. And it's, to be quite honest with you, in our organization, we have been practicing based on evidence and have moved towards a principle-based philosophy. I know we threw out our detailed procedure manuals years ago and moved towards that probably about 20 years ago. And I have found it to be incredibly freeing because, and I think our staff have too, because they have guidelines and principles to help guide their decision making along with the evidence and tools that we give them. But within the community and the home care environment, it's very difficult to standardize everything. Because, as each one of us lives on our own homes, there's nothing standardized about a home environment, and there's nothing standardized about people living in a home environment. So I think by moving towards a principle-based practice, philosophy, and a culture within that, I think is pretty great, and I don't think we need a policy around that. What I do think we need to do is we need to make sure that our policies around things, around care, around practice issues are evidence-based, and that we're citing the research evidence that we're using, or we're citing the legislation that we're using to inform and guide our policies or our practices, more so than having that broader policy around we're a principle-based organization.
Karen, anything to add?
I would just echo Nancy's comments with regards to we've really moved away from having more of the procedural-based policies in the hospital, and I think a lot of that is really the function of the speed at which things change. keeping up with a policy and procedure manual on an annual basis can be very daunting. I mean, we have two acute care sites. I'm not sure how we would manage that. And to Nancy's point, it's really important that the policies that you do have are really based on the evidence and are really providing guidance around the principles that are required, but do allow the nurse adequate flexibility to individualize that to the patient's needs. We can become very structured with policies and looking at the difference between a principle-based document versus a more robust, 35-page document really can become very stringent and doesn't allow that critical inquiry and critical thinking and application of evidence that we're really wanting nurses to use in their practice. So I think it'll be a transition, but I think it'll be a great thing for nursing practice.
This slide highlights key attributes of a knowledge-based practice as stated in the EntryDepressed Competencies again. Critical thinking and evidence-informed decision-making are essential components of all phases of the nursing process. Just remember that evaluation is also a key part of critical inquiry, and that has been already mentioned by our speakers. So really that need to look at new ideas when determining whether or not other change is required. When reviewing information on evidence-informed practice, a researcher advised to start small, stay curious, discard what doesn't work. So Nancy, can you give suggestions on where you would start when implementing evidence-informed practice in your setting?
Sure. Well, I mean, again, it kind of goes back to a whole, really a cultural change within the organization in some cases. In other cases, it's just reaffirming the philosophy that already exists within the organization. But, we've had the greatest success here by aligning our focus on evidence-informed practice, and not just on practice. We also use evidence to inform decision-making at a managerial organizational perspective. So, aligning everything within the organization, kind of undertaking an assessment to determine where in the organization, where are you practicing based on evidence well, where do you think there's some gaps, what are the enablers, what are the barriers, and then looking at implementing multiple and creating multiple strategies to address both the barriers, to take down those barriers, but also looking at what's really working well and where you have some great practices happening, whether they're on a unit or in a team or in a home, that are really advancing things and working well, and maximize and capitalize on those. I think, as always, you have to have champions and cheerleaders for evidence-informed practice who can actually distill what it really looks like at the front line and can be great role models for moving things forward. And I think, evaluation, you touched on that, evaluating how you're doing, back to what the researcher says, discard what isn't working and try something new. I think there are lots of good resources out there. We worked a lot with the RNAO and as a best practice spotlight organization, and used their best practice guidelines really as a catalyst to be figuring out how to embed and sustain a culture that uses evidence to inform practice, because I think, in general, there are very many practitioners that do this all the time anyways, and I think in some cases, we do it without even knowing that we're doing it. But I think sometimes we need catalysts to galvanize, as Karen said earlier, to galvanize our collective knowledge together to be improving things and moving things forward. So, those are some of the things that I would suggest are important within organizations, that certainly leaders within organizations can do, and champions can be supportive of driving things through as well.
Great. Karen?
Sure. I'll just add to that, and I think we've kind of spoken about it a little bit throughout the course of the presentation so far, is just a small test of change. And just in case anybody on the call isn't that familiar with it, I thought it might be worthwhile just to expand on it a little bit. So when we're doing these small tests of change with quality improvement, we're really looking at not trying to tackle the 150-page practice guideline that we've identified. We're really looking at picking out one small intervention that's easily implemented, that we can try. And we'll start with one nurse, that's willing, that champion on the unit that's willing to try it with one patient, and we'll evaluate and see how it goes. And if it goes well, we'll do it with 2 patients and 4 patients, and then we'll move it to a second nurse. And we'll really move it through that way so that over the course of a week, we've done it in a low-key way. It's not threatening at all. We've gotten the early adopters engaged, and really other people start to see it, and it's surprising how quickly a positive change can spread on a unit without really trying that hard. And if it doesn't work on that first day or that second day, then you can stop doing it. If it's not something that's going to meet your population needs, if it's something that you need additional resources for, you can take a step back. Rather than, kind of the old school, even I was going to say 20 years ago, but even 10 years ago, putting a whole change in place and then having to take a step back 6 months later when you realize that you haven't really addressed some of the barriers in the workplace. So starting small really is a great and effective way to make changes.
Mm-hmm. Okay, thank you to both of you. Karen, maybe would you be able to identify any particular tools or other resources that would be supportive of nurses in moving toward knowledge-based practice or evidence-informed practice?
Sure. Nancy identified some great ones, particularly the RNAO. We're all familiar with the best practice guidelines, and they have some great workshops. We've hosted a couple on site. You can sign up your organization, and they'll come down and provide the workshop for your staff and for other interested parties in the community. We've partnered with our various nursing societies, so whether it's the Honor Society, the local RNAO chapter in your city or area, and your associations, so your Critical Care Nurses Association, the Emergency Nursing Association, the Operating Room Nursing Association. Each association really has a great network, lots of guidelines. The CNO obviously is a great resource with its practice consultant line. The Canadian Nursing Association has great documents that are available, and they can really help provide a starting point for you. They might not provide all the answers, but they certainly provide some structure of where you might want to go when you're looking at practice changes. I talked about professional networks a little bit, but certainly there's a great online community available. There's many listservs that are based or out from professional associations that are great resources. It really helps from a networking perspective to connect you with other people that work in similar practice settings, specialty interest groups, for example. Lots of great resources online, again, but just being very careful when you're looking at those resources that they are evidence-based. I think we've all had our patients come to us with wild and wonderful things that they might have found Googling or on Wikipedia, and we have to be careful as practitioners that we ourselves are accessing evidence-based resources. So, again, looking at the associations that we know that are evidence-based, whether it's Diabetes Association, Heart and Stroke, Alzheimer's Association, they will give us not only great resources that we can share with our patients, but they'll also have the literature referenced and available for you. So that can be a really quick way to identify where the best evidence might be. And never underestimate talking to people, connecting with colleagues at other facilities. I find anymore that it's very easy to connect with other hospitals and get information and just ask them. And if you've got a particular challenge, find a connection at another hospital and let them know what you're challenged with, and ask if they have something that they would be willing to share. And for the vast majority of times that I've asked, I've gotten more than I could have ever wanted. So don't forget about your experienced colleagues that might be in another building.
The next slide, slide 13, looks at EntryDepressed Competencies again, and these refer to a nurse's specialized body of knowledge. The indicators in this slide further demonstrate aspects of the processes of critical inquiry and evidence-informed practice. So if we just start with the basics, Nancy, do you have suggestions on how to determine best practice?
I think in terms of looking at best practice, Karen did a great job of really touching on some of that last time. And, part of it is considering the source. looking at who is the expert and their qualifications behind the information or the evidence. If we're looking at policies or guidelines, looking at what's the qualified evidence that's behind those types of behind that type of evidence or those policies or procedures, and looking at standards that have also come out from credible organizations such as the associations that Karen mentioned, the CDA, the Heart and Stroke. So I think it's really being mindful of where you're accessing that information, because often we tend to seek information from our most trusted colleague, and our most trusted colleague may not be the individual with the best evidence at hand. So if we think about, where are they practicing, where are they getting their evidence from, is it a credible source? On the website, are they credible sources? Are those organizations known for putting out good, credible information? And in fact, there was just recently a systematic review done that took a look at all of the evidence that's put out by a variety of organizations and has listed from like 1 to 30, how those organizations rank in putting out research evidence and the credibility of their research evidence. So I'll probably get back to you on that, because that would be something good to share with people as well.
Thanks, Nancy. Karen?
Yeah, I would just support what Nancy has just said. I don't really have anything to add after I went on and on at the last question.
Practice environment has a major impact on how a nurse practices in their setting. In previous slides, just sort of a summary, we talked about organizational supports and the importance of policy, procedures, and other organizational supports. One of the initial slides depicted the interrelationship between the client, the nurse, CNO documents, legislation, and the organization. Multiple CNO documents refer to the attributes of a quality practice setting in relation to the application of the college documents within the practice setting. For example, Therapeutic Nurse-Client Relationships talks about the need for an organization to promote reflective practice as a means of supporting client-centered care. A key component of this environment is the need to work collaboratively to promote an organizational culture of respect with colleagues. The professional standards reiterate the need for administrators to support and contribute to practice environments that encourage learning and the application of nursing knowledge and research. One of the comments that we've heard frequently is, this sounds great in theory, but I work alone in my practice. Do I still need to use evidence-informed practice when I have my own business? Yes. The College of Nurses Independent Practice document talks about the accountability to comply with CNO expectations, along with the college's requirements for ongoing continued competence, such as the need for reflective practice and engaging in ongoing continuous learning, concepts we've discussed today. Given the autonomous nature of independent nursing practice, you may need to participate in professional networks and identify peers for support and collaboration. It's important to reiterate that all nurses have a responsibility for leadership and advocacy.
So we're going to open your line to questions in a minute, but in summary, the importance of reflecting on your learning needs and lifelong learning cannot be underestimated. Information is developing at a fast pace, and to provide evidence-informed nursing care, our learning needs to be continuous. The above quotation demonstrates that we may not see change on a day-to-day basis, but that it is happening, whether we recognize it or not. As nurses, we have an accountability to recognize it and to take action to provide optimal, safe, and ethical nursing care. So there are a number of CNO documents that I would like to acknowledge for the listeners today. The documents that we have referenced are available on the CNO website, along with all of the other college documents. Other educational tools that you may be interested in, such as webcasts, our Ask Practice questions, frequently asked questions, and learning modules, are available on the CNO website. We do have one other question for Nancy and Karen. So what do you do if you're participating in a culture that does not support collaboration and integration of research? Nancy, maybe you can begin, and Karen, if you can add after.
Well, I mean, I think that you're never totally alone as an independent practitioner or in an organization perhaps that doesn't provide a lot of support. There are, as Karen mentioned earlier, there are a lot of networks, there are a lot of resources, there are a lot of individuals and specialist colleagues out there, And I think, looking inside your organization for others, other like-minded people, looking at resources outside of your organization. And I know even with in home care, where people would tend to think we're fairly isolated and have limited resources, we've actually come together, nursing leaders, as a nursing practice council of both for-profit and not-for-profit healthcare organizations, to be supporting one another in the creation of evidence-based policies to actually move forward good practice within the home care setting. So I think you look inside. If you can't find it inside, then you look outside, and there's plenty of resources outside to support good practice and evidence-informed practice in a new way.
Great, thank you. And Karen, anything to add?
I think Nancy really summed it up really well. I think look inside and then look outside. And really, just to reiterate what we talked about with regards to quality improvement, if you're looking at improving the support for critical inquiry in your workplace and looking at collaborative practice, start small. Bring an article to a staff meeting. Try and have some small discussions with your colleagues while you're working. Bring up something interesting that you might have read or seen or learned about at a workshop. You can start having those discussions yourself to start moving those things forward.
Mm-hmm. That's a very good point.
Great. Thank you to both of you. Go ahead, Myra.
I was just going to mention, just to add on to what Karen and Nancy talked when we were talking about the collaborative, when you're working in a culture that doesn't support the collaboration and integration of research, I think where we hear this most often is from nurses working independently, or also nurses working for the non-nursing manager or organization. And what we've suggested in this case as well from the college perspective is to take your employer or your manager back to the standards. So when you're working for someone who is non-regulated, show them what it means to be self-regulated, and also raise awareness of accountabilities. So those are just a couple of things to add there.
Yep.
Mm-hmm. Yeah, it's a good point, because sometimes it's a lack of understanding and awareness as it relates to clinical practice accountabilities and college requirements, etc.
With that, then, I will ask everyone to look at slide 18, and we do hope that this teleconference has provided you with guidance in relation to the expectations for critical inquiry and evidence-informed practice. We would like to thank our guest speakers today, Nancy Lefebre and Karen Riddell, for sharing their expertise with us. Your application of concepts to the practice setting was invaluable. Many thanks. We thank everyone for taking time to join us today. Thank you and goodbye.